Now we're ready. Oh, short. Dang, physicist in the audience.
Would you like me to introduce you?
No, I can introduce myself. But you're welcome to introduce me.
All right, I'll introduce you. And put the end. Hi everyone, my name is Tracy McKinney. I work in Wilmot Shared Resources. Today we are here presenting on the imaging and radiation shared resource. Brian Marples leads the radiation side of that shared resource. This Lunch and Learn series is part of a series. We offer on the second Tuesday of every month. Next month we'll be featuring another psychometry talk on spectral psychometers. And this is being offered in part to Vivian Calidoro for endowment to Wilmot, and her funds go collectively towards supporting shared resources, in particular this lunch and learn seminar. So, please come, it's a monthly event, and in our registration survey we do have all the questions, so if you want to be added to the list, you can check yes, and I'll just email you when I start sending out all the emails to admins and everything. But Brian's going to talk to you today about radiation and dosimetry services offered by the shared resource.
Okay. First of all, thank you for coming. This is way too high to see, and this is way too low to see because of my focal length, so I'm going to wander. Thank you to the people that submitted questions prior to the seminar, that Tracy forwarded. The slides in the seminar address the questions that were submitted. So if you don't like the seminar, send me the questions. It's a simple solution. So we're going to talk around those questions in terms of the shared resource, what we offer towards the back end, and why we offer what we do at the front end. But for a lot of people in here, they're not radiation core people, so I put some slides up front with a little bit of history, why we do what we do, and then describe our machines. Please feel free to ask questions and interrupt. I will not be offended. So we're at the shared resource lunch and learn, imaging a shared radiation resource. And the question I put out was, do you know what radiation dose you are giving and why you're giving that dose? Important questions, often ignored by people in their publications, and more importantly in their grant submissions. These are critical questions that reviewers ask over and over again. So at the front, I've tried to address that question. At the back end, I'll show you our technology. This is Röntgen, Wilhelm Röntgen, who discovered X-rays in 1985, published in December 1985, so it's often cited as 1986. But he developed the first X-ray tube to generate X-rays. Wasn't very effective, but it worked. So what we're going to talk about today is our animal irradiators, for those who do animal work, cell irradiation, dosimetry that we can offer, whether we do it with you or you do it yourself, and education in terms of what you're targeting and why you're targeting and what dose you're selecting. That's what we offer as a service for the shared resource. We also offer support, and that's help in you as an investigator design your experiment, select your dose, select your fractionation scheme, and analysis in terms of radiation response and what we can give to help your manuscript or grant in terms of our dosimetry services. Language that's required if you're submitting a grant with radiation to the NIH or the NCI. We're happy to talk about those. You just have to contact us through the shared resource. So what we're going to talk about today is, do you know what radiation dose you're giving and why? Are you giving a single dose, a large single dose to get a large effect, to measure an effect? Or are you going to be clinically relevant and give a fractionated treatment with lower dose fractions? And if so, how many fractions and at what interval? Clearly, it's easier to give a single dose as a one-off, but fractionated is more relevant for clinical translation and scores with reviewers who are radiation focused. How are you defining the treatment volume? In other words, you're shooting a radiation beam at something, how are you defining that target, and what volume of that target you're irradiating? Are you doing a whole animal for TBI, total body, or you're doing just a tumour or normal tissue? How do you define that? And is it important? Is it important to do the whole lung or just part of the lung if you're looking at lung effects? The whole bladder or part of the bladder if you're looking at bladder effects? Or the whole tumour or part of the tumour if you're looking at tumour response? We can discuss that. Are you irradiating cells and plastic, animals, or tumours? Animals in normal tissue or tumours. If you're doing cells in plastic, the response of those cells in plastic will depend on how quickly those cells are proliferating. Confluence-arrested cells have got a different radiation response to proliferating, logarithmically growing cells. And the distribution of cells in that cell population affect your radiation response, and that effect is more pronounced the higher the dose you go. So growth kinetics and tumor kinetics are important in selecting your dose and fraction size. So if you're doing normal tissue tolerance, a lot of my work is in normal tissue tolerance in the kidney and the bladder. Do we irradiate the whole organ, partial organ, to what dose? Or if you're just doing TBI, what dose are you using for your total body irradiation, say, for example, to eradicate bone marrow? These are all critical questions. A single dose of 9 gray, 10 gray, or 5 times 2 gray fractions with a 24-hour interval. They all affect the radiation response. As a radiation biologist, that's important to me. The tumour study is not a curative, so you're just trying to cure the tumour, and if you cure the tumour, the animal survives. Do you leave that animal going and measure normal tissue toxicities for your curative dose, which invariably will be a high dose? Or are you simply looking at inhibition of tumour growth as your outcome? And in that case, the animal invariably will survive long. You're not interested in normal tissue toxicity. But normal tissue toxicity in response to your tumour defines your therapeutic ratio. And if you're putting a grant in that is involving radiation and you don't discuss the therapeutic ratio, it's the lowest hanging fruit for a reviewer. Is your radiation combined with another modality? There's a lot of work in the Cancer Centre, from Scott Gerber's group, looking at radiation combined with immunotherapy, using radiation to prime the immunotherapy response. What is the sequence? Do you give it 24 hours after, 48 hours after, at the same time? Immunotherapy first, then radiation. We can talk about how that sequencing works, and that is dependent on the fraction size, to some extent, you use for radiation studies. And more importantly, and there's a physicist in the audience who will reinforce this point, that over there, radiation dosimetry is important. You have to validate the dose you give, and we do that in the shared resource. And if you don't validate the dose you give, and you put a grant in without dose validation, that's the lowest hanging fruit for the reviewer to say they don't know what doses they're giving. It's a requirement. And Sean does all our dosimetry as a board-certified clinical physicist. So we have the best of both worlds. So let's look at some history just to get us oriented. This is the first documented case of radiation being used for an anti-tumor response. It's from Sweden, Steinbeck, curing a basal carcinoma here with 99 fractions of X-rays. You'll notice the date. Well, you won't notice the date because it's covered, but it's 1899. It's a year or two after the discovery of X-rays. The tubes weren't efficient. Dosimetry was challenging at best, so they didn't really know what dose they were giving. It was a trial and error approach. But you can see there's efficacy. Similar work on Emil Grubb in the US, looking at hairy nevus and various other basal cell carcinomas of the skin. Early treatments, poor dosimetry, not very well penetrating, so most of the early work is on the skin. But dosimetry was trial and error. We jump ahead a long way, the 1950s. This is from the UK in Newcastle. You can see the machine here. It rotates. It's higher energy, so it's more penetration, and it's an isocentric therapy machine. Isocentric means there's multiple beams, and they focus the center of the beams to overlap the desired planning treatment volume, the PTV, the target. So this was quite an innovation because it was the first isocentric therapy machine with sufficient energy to cause some penetration, and this is a breast cancer treatment from Newcastle. That's in the UK. The US was the same. This is actually taken from a publication from Kaplan and at Stanford, who worked with the Varian brothers. For those that know, Varian now make the majority of radiation therapy linacs in the clinic today. But this is a child who was treated for retinoblastoma, and here's the X-ray head. So having just said, do you know what volume you're irradiating, and do you know what dose you're giving? This example and this prior example, yes, we know the dose, but you should be thinking that the targeting is challenging. Can they get this poor 7-year-old kid to sit in the same place so they can give a radiation beam to the retinoblastoma consistently? So in these early studies, there was very little targeting. That was developed more or later and is now current in most modern linac treatments. Either the patient's screwed down at the table or they use imaging from MR or CT to try and define it. And you can see that. It's just highlighting the fact that you've got to localize the target. You can see that in this panel. And this is a random thing I took from the literature yesterday morning. It's looking at VMAT of ARC therapy. This is our prostate in the middle. This is the dose scale, so you can see most of the doses in the prostate and the normal tissue surround at a low dose bath. But I've put this up to demonstrate modern contemporary linac or radiation therapy uses image guidance as well as dose verification. And that is really done here with our dose volume histogram. This is the volume of tissue receiving the dose. And you can see here for the blue, the PTV, the planning treatment volume, which is the prostate. The 100% of the prostate gets the required dose. And you can see here, this is a predicted dose, a delivered dose, and the real ground truth. So we really target the prostate with the actual dose required, and the normal tissues, in this case, the bladder or the right and left femoral heads, get a lower dose. So the dose is verified in the clinic by imaging and people like Sean with his physics team. So that's what happens clinically. So we can see we do the dose, we do dose verification. Towards the back end of this talk, I'll show you the same approaches we use with a SAR to validate experimental dosimetry. But before we do that, we talked earlier on about single dose or about fractionated treatment. What is the difference between giving a large single dose or multiple fractions of a lower fraction size? Total dose is not the same. 5 fractions of 5 gray is not the same as a single dose of 25 gray. In that interfraction interval, we start seeing biological effects that affect the radiation response of subsequent fractions. One of the most classic examples of this was by Claude Rigaud in Lyon, France. He demonstrated with rams and rabbits using the scrotum as a model for a tumor, because it's a proliferating normal tissue surrounded by normal skin. I see people find this smile, I smile at it as well. This is a really classic experiment using a normal tissue to replicate a tumor response. So what he demonstrated in this is if he gave a large single dose, he could sterilize the ram, but he caused lots of normal tissue toxicity. Unacceptable therapeutic outcome. If he fractionated, he could still sterilize the ram. That's his model for curing the tumor without causing scrotal damage. He did it in a ram, he did it in a rabbit, and this is a kind of old textbook. We probably wouldn't put a beret in the Eiffel Tower there now, but classic example. So that was 1927. In the 1930s, Henry Coulthard, also in Lyon, did a similar work in a human patient population for head and neck cancers. In this study from Coulthard, he was not concerned with tumor response. He was concerned with normal tissue toxicity. And he demonstrated for the same dose in Hounsfield units here, if you change the duration for 14 days, 10 days, or 18 days, you got a different normal tissue response. If you compress the schedule to 10 days with 2 doses either side of the neck, you've got overlapping normal tissue toxicities. This is our mucous membrane, this is our skin. If you prolonged therapy, you could prevent overlapping toxicities, which is good for the patient. But it might be bad for normal tissue, for normal tumor control. And much like the 3 bears and whatever it was, who was with 3 bears? It wasn't Cinderella, who? Goldilocks. Much like Goldilocks, you can get an optimal, just right schedule for this and demonstrate that if you go the right duration, you've got non-overlapping toxicities, but also a greater probability of tumor cure. So in these early studies, they were concerned about toxicity, not tumor efficacy. The French led the field, the Germans took over, they went to the UK to do all the biology, and then we're back over in the US. This is Michalowski from Poland, who worked closely with a lot of the early radiation biologists, and he demonstrated that normal tissues have 2 types of response. The normal tissue either has a stem cell, that makes transit cells, post-mitotic functional cells, and eventually the cells die as they slough off. That will be the gut and the skin. In terms of radiation response, if you give a sufficiently high dose, you can damage transit cells, but if the dose is sufficiently high and you kill all the stem cells, you're going to get a very quick acute reaction when all the transit cells have died and there's no stem cell producing new transit cells to cause toxicity. So this we see an acute response that happens a couple of weeks after therapy, 3 to 4 weeks or 2 to 4 weeks after therapy, for those acutely responding normal tissues like the skin and gut. Other tissues, kidney and lung, which are much more developed, more differentiated, less cell proliferation, they show a different response to radiation therapy. That response occurs late after dosing. That could be months or even years in terms of fibrosis. And the difference is here, the tissue's much more differentiated, vascular cells, endothelial cells, fibroblasts, parenchymal functional cells of the tissue, and you get immune cells invading that. And the damage response to radiation really affects the damage to the underlying parenchymal cells, but also the change in the environment of that tissue that determines the functional consequences, and the really evident consequences really reflect the loss of tissue function primarily driven by fibrosis responses, TGF-beta and all the SMADs. So we see more vascular components involved in late responses. So if you are doing radiation studies with a tumor and the tumor is subcutaneous, the skin might be your big concern. But if you're doing an orthotopic tumor in the kidney, late responding normal tissues may be a concern, and the expression of that normal tissue damage will depend on time and the dose. So you have to be cognizant of where your tumor is in a mouse if you're using radiation. This is a much simplified approach from Michalowski. Howard Thames and colleagues, Lester Peters, demonstrated that there's also the tissue is organized in serial and parallel organizations. There's a concept called tissue rescue units. It's a number of functional cells that can recover that tissue. So it's more complex than this binary approach. But all this is well defined in terms of radiation biology. That's all the literature combined. There's a really nice review written by Holly Barker and colleagues that I would recommend if you're interested in this, you look at. It addresses all this early radiation biology that can be kind of difficult to find in the literature. And in this manuscript, Barker and colleagues talk about the early acute responses reflecting DNA damage, cell death and inflammation, death of the vascular cells, leading to these acute responses because of loss of damaged stem cells, but then much later effects that occur weeks, months, and years after therapy, reflecting TGF-beta signaling and fibrosis, damage to the parenchymal cells and vasculature, leading to these late effects. And they demonstrated in this that the late effects, the latency, so when that late effect develops, is proportional to dose. The higher your single dose, the quicker that latency occurs. So in our mouse model of bladder injury, if we give a large 30-gray single dose which lacks complete clinical relevance, we see maturation and functional changes in the bladder after about 14 weeks. But if we give 15 gray, so half the dose, single dose, we're waiting 30 or 40 weeks before we see that same level of toxicity. So all that's got to be considered when you're doing your planning. The other thing to consider is radiation doesn't often have a linear dose response in lot of molecular approaches. Another nice review showing radiation and inflammation, because inflammation is all the rage, at low doses or intermediate doses, 0.1 to 1 gray, or greater than 1 gray, we see there's a different response in pro-inflammatory responses. At higher doses, we see pro-inflammatory responses. At lower doses, we see an anti-inflammatory response. So the effect, or the biological effect you're measuring after radiation may not have a linear dose response. DNA damage has a linear dose response. Recovery and repair has less of a linear dose response, and inflammation, not really a linear dose response. So there are several things to consider in your dose selection for what you are measuring. It's all in the literature, but it's buried, and we can unearth it if we sit and have a conversation before you start using imaging and radiation shared resource. So we see dichotomous response. So let's get back to that question of single dose and fractionated dosing. How do we measure radiation survival? And how do we define what dose we give? This is a survival curve taken from a manuscript. It's not really labeled very well. This is surviving fraction on a log scale. Dose, radiation dose on a ln scale. We always plot log ln, and when we plot log ln scale, we see a nice shouldered survival curve. The reason this is relevant is you can see two shapes on here. There's a different response whether you are an earlier responding acute normal tissue like the skin and gut and a tumour. You see a much more shallow shoulder, whereas late responding normal tissues like the kidney and the lung, the liver, that show these late effects, we see a much more shouldered response to single doses. And that tells you that these tissues and tumours respond differently depending on the size of the fraction that you use to treat. So a large dose fraction in an acute and a chronic tissue, or an acute and a tumour, will be different in terms of their outcome. So it's not appropriate to arbitrarily pick a 10 gray dose, because a 10 gray dose will have a different response in a tumour and acute compared with a chronic responding normal tissue. There needs to be some biological rationale for the dose you pick, not just picking 10 gray because it's a nice round number. This is after single doses, but if we look at a fractionated plot, this is survival against dose, again on a log ln scale. This is our single dose survival curve, and you can see when you fractionate with these individual fractions, you replicate the shoulder of the survival curve because of DNA repair. And if you then go up across here from total dose, and compare the single dose with the fractionated and go up there and measure survival along here, you can see there's much more sparing of radiation-induced killing when we fractionate, when you compare to the same total dose given as a single fraction. And this will vary based on your tumour type, your specific tumour, and your normal tissue. So why is this really important? This is classic work here, written by Rod Withers, describing the 4 R's of radiation biology. In that interfraction interval, your fractionated schedule, we see repair of DNA damage, and repair of sublethal injury. We see reoxygenation of the tumour, because we're killing off the sensitive oxygenated cells. The surviving hypoxic cells then become reoxygenated, so in that interfraction interval, we're sensitizing the tumour. We see redistribution of cells through the division cycle. We know S-phase cells are more radiation resistant, so when we irradiate that first fraction, we maybe kill off some G1 phase cells and some G2 phase cells. The surviving resistant S-phase cells in that interfraction interval move around the cell cycle into a radiation sensitive phase or more radiation sensitive phase. And in that interfraction interval, we allow regeneration of the normal tissues to repopulate and spare normal tissue injury. So we fractionate for a whole range of reasons. So clinically, we fractionate with 2 gray fractions conventionally, 35 fractions of 2 gray, total dose of 70 gray over 7 weeks with the weekends off, and we fractionate to allow recovery of the normal tissue, but with a sufficient dose that we get tumor cure. And that's been really defined by clinical studies and clinical trials. Gordon Steele then added radiosensitivity as a 5th R because we know tumor cells have aberrant genomic backgrounds and that genomic effect influences repair. If you've got a BRCA1 deficiency, that's going to affect homologous recombination repair. So sensitivity is important. So all this happens in an interfraction interval between your fractions. So if you're measuring or studying tumor hypoxia, and you give a single dose of radiation to cure your tumor or cause tumor cell kill, there's no reoxygenation, there's no interfraction interval, it's a single dose. If you send a grant in measuring tumor hypoxia, using just single doses to irradiate your tumor, it's never going to get discussed. You have to fractionate if you're considering hypoxia as a therapy for tumor response, to address therapy for tumor response. So you have to consider all these R's when you design your experiment. And at the Shared Resource, we offer that as a service to look at your experimental design, to look at what you're trying to achieve, and develop the appropriate dosing regimen for your experiment. Why is this important? The big question. This is important. Some different graph from Howard Thames, Rod Withers, Lester Peters. Surviving fraction against dose on a log-lin scale. This is our tumor and early responding normal tissues where each dose increment gives about the same level of cell kill. Our late responding normal tissues, you can see it's bending the survival curve. So as the dose increases this way, we get more killing per unit dose. High dose fractions cause more killing per unit dose than at low dose fractions. And if you extrapolate all this in the world's worst plot, but at the same time the world's best plot, and I say worst because this is the scale, dose fraction size, it's inverted, this is the high dose fraction, and it's logarithmic, this way, dose fraction, and this is total dose for causing an ISO effect in normal tissue or tumor response, again, with a strange logarithmic scale. But at least it's going in the right direction. And on this plot, we can see 2 shapes or 2 responses, lines that are dashed blue and lines that are solid gray, brown. You can see that the brown lines are steeper than the dashed blue lines. And because they're steeper, that tells us once you start increasing dose per fraction this way, you need a lower total dose to cause the same ISO effects. In other words, normal tissues and tumors that have a steep response are more sensitive when we change that fraction size. So if you're arbitrarily picking 4 gray, 6 gray, 8 gray, or 10 gray fractions, or single doses, there's going to be a different response in the tumor and the normal tissue, and we can predict that from this plot using our alpha beta ratio, which is just a measure of the bendiness of that survival curve. So again, arbitrarily picking doses is not the way to go. You have to have a biological rationale for selecting your single dose and your fractionated treatments. So these are our 4 R's of radiation biology, and you think I don't do radiation work, I'm not a radiation biologist, frankly my dear, it's not important for it. But it relates to tumor biology. We're all familiar with those Weinberg and Hallahan papers describing hallmarks of cancer. This publication here from Kevin Harrington and colleagues relates the 4 R's of radiation biology directly with hallmarks of cancer. the evasion, the angiogenesis, the evasion of cell death, growth factor stimulation. So what was defined in radiobiology in the 60s, 70s, and 80s relates to what we know of the genomic state of tumors in terms of the hallmarks of cancer. So it is relevant to what you're doing if you're doing tumor studies, even though it's radiation specific. Okay, that's the background. Now you're all qualified radiation biologists. You can then talk more specifically about the questions we need addressing for this survey. So this is what we offer in the imaging and radiation shared resource. We have primarily three irradiators, the small animal radiation research platform. To use this, you irradiate mice with this. It needs to be on your UCAR protocol. We'll check. If you tell us it's on the protocol, we'll check that it's on the protocol. Likewise, if you use the gamma cell cesium irradiator, which is inside the animal house, behind the barrier, which is primarily used for total body irradiation, we'll see a picture later on, that needs to be on your protocol. If you use the Shepherd cesium irradiator in the basement, which can be used for animal studies and for TBI, that needs to be on your protocol. You can see a theme here. If you're irradiating an animal, the machine needs to be on your UCAR protocol. So whether you use any of these machines, what we can offer is dosimetry services. And there's an example I've got later on showing that we did validate dosimetry for a study where that was challenging. And the language I like to use in my grants is that the radiation research, imaging and radiation shared research verifies adherence to nationally recognized dosimetric standards to ensure experimental reproducibility. And this is the Association of Medical Physicists, and this is their Task Group 61 report that tells you how to measure dosimetry. I get around this by putting the language in, and I collaborate with a clinical physicist, and he's on my grants. He takes away all questions about dosimetry and whether I know I'm giving the doses I give, because my grants go to radiation study boards. We can do this dose volume histogram on an animal by animal basis. It gives confidence that we know what we're doing correctly. So this is a small animal radiation research platform. It's down on the ground floor in a room that's kind of difficult to find. We use image-guided treatments, and you'll see an example in a picture later on. In the clinic, they use image-guided treatments. We've got a CT imager. They have a much more sophisticated one, but we target with CT imaging. So we're clinically relevant. We use a collimated field size. We can change the size of the beam from a small diameter to a square to a variable collimator to target the volume we need. They do that in the clinic, so ours is clinically relevant. We look at dose volume histogram panning to show that we give the dose to the target with minimal dose to surrounding normal tissue. Same thing we've just seen in the clinical example. We give individual personalized treatments. Each mouse is treated individually as an individual patient. They're anesthetized, we take a CT image, we plan based on the tumor in that specific animal. So again, we're replicating what's happening in the clinic. If we're doing basic preclinical translation, basic preclinical work, we aim to translate into the clinic. In our grant, we write, we are using clinically relevant protocols for our tumor work and our normal tissue work. The SARP is operated by shared resource staff, but also users from the investigation team to do all the animal manipulation, putting them on the machine and when we irradiate. It takes about 2 to 3 weeks lead time to schedule. You can contact Lily McFadden to do scheduling, and it's about $200 an hour, and we get a 50% reduction for Wilmot members. It may seem a lot, but because of the precision, your N or your cohort size can be reduced because you're getting less variability mouse to mouse, because you're really targeting what you want to irradiate. So there's an offset in terms of cost and cohort size that we can offer with a SARP because we're doing more precision targeting and therefore more reproducibility. And it plays well to reviewers of grants and reviewers of manuscripts. This is a simple picture, not the best, but a simple picture showing Scott Gerber pointing to the mouse bed. Our mouse bed lies on here. This is our collimator. We can change the brass collimator at the end to change the size of the beam. And this is the X-ray head, and this X-ray head can rotate this way, and it can rotate that way. And we can give multiple beams on a specific ISO center. Again, replicating what happens in the clinic. So if you're doing radiation studies in animals and tumor work, you need to be using the SARP. So we put our mouse on this bed, looks like a patient lies on a bed, and then we irradiate through here. That's in the room. When the beam's operational, the individuals pointing in this picture leave the room, sit behind the wall, and then we do a radiation separate. Okay, so this is showing what we can do. The SARP has a planning strategy called Neuroplan. It allows us to plan treatments. This is one of my mice. You can see the various aspects. We're irradiating with a beam going straight through the bladder, and you can see here the bladder is specifically targeted with a square collimated beam to cover 100% of the bladder. And in this study, we're measuring radiation-induced toxicity in the bladder as part of a prostate project. And if we look at our dose volume histogram, fraction of dose against dose, this is a 8-grade dose here. The bladder gets all the dose, and the surrounding normal tissues in the spine and in the kidney get minimal dose. We put this in our grants. It shows we can target. We've got a good therapeutic ratio. And we identify the bladder here by using a contrast agent. We inject a contrast agent, it goes to the kidneys, it's quickly in the bladder. We use that for our targeting approach. And you can see here, there's a little bit of contrast in the bladder, and that's our ISO center that we're putting our multiple beams in, and there's the contrast in the bladder to identify it with our CT imaging. This is work from Brendan Whitelaw that Sean helped us with the dosimetry on here. He was looking at the effect of radiation in the brain and the recruitment of microglia in the irradiated brain. So we had a window chamber in the skull of his mouse that was surgically implanted, and then after 3 weeks, he irradiated with a dose of 10 gray. And there was a concern here that the window chamber itself was supported by a metal frame, and we know metal interferes with the radiation response and can cause some artifacts. So with Sean, we measured the dose in the brain, and we measured the dose below the brain, and we validated for his 10 gray on one beam. Here's the 10 gray dose, the dose volume histogram, but using radiopaque film that was implanted into the animal, we validated under the window and at the midline of the brain, we were getting the required 5 gray dose, 5 gray from one beam, 5 gray from another beam. And we validated the dosimetry and demonstrated in this publication that the frame itself was not causing a radiation effect. And once we'd irradiated, he measured recruitment and change of microglial numbers through his window with time, and we published it and demonstrated that in that model, he was giving the dose that he wanted. Okay, a few more examples and then we'll wrap up. This is work, Manji Groves, my group. Look, it's the animal. She's giving hemilung irradiation. So we just irradiated one lung. You can see in the various planes, we've got a nice conformal beam just irradiating one lung of the animal. And the rationale here is she was comparing the controls with an irradiated lung and what happened in that contralateral lung to the irradiated lung and comparing that directly with the irradiated lung. So she was looking at the recruitment of macrophages and immune cells in the lung that was targeted, but also the ipsilateral lung that was not targeted to look at communication of immune responses in the lung for partially irradiated lung. And you can see from here, we've got, well, we could see, but I can't read it because it's repeated. We've got, this is our targeted lung with our 6 gray dose. We can see down here in the liver, down here didn't get a dose, thymus didn't get a dose, the heart didn't get a dose, and the contralateral lung also received almost minimal dose. So we can see we targeted this area and the surrounding normal tissue got minimal dose. Validating our experimental model. This is tumor work from Scott Gerber's group. He's done a lot of this. They're actually irradiating now. What they do is they have a pancreas model, or they have a colon model, or a liver model. They do surgical implanting of fiducial markers in that organ. Then they implant the tumor between those fiducial markers, and we can identify the fiducial markers on our CT scan. So here's the surgery, here's the fiducial markers here, here's the tumour here. On our CT scan, here's the fiducial markers, therefore the tumour must be in the middle, and we irradiate to target the interval, the gap between those fiducial markers, demonstrating we have dose to that tumour. And the reason this is important is in Scott's work, they give standard 6-gray fractions over 4 days or 5 fractions over 5 days, and they need to reproducibly target the dose specifically to the tumour. And we can give reproducible targeting because we're using these fiducial markers to ensure we're giving reproducible targeting on an animal by animal basis. So then he adds IL-12 afterwards to generate an immune response. And this is similar work from the same group rather than pancreas. This is a rectal tumour. You can see here the fiducial markers. Here's our tumour here, and then we look at areas outside beam targeting, which is in a mauve colour here, with our isocenter in the red circle. And you can see from across 2 sections, and when we do our dose volume histogram, giving 5-gray, we get the rectal tumour, get 100% of the tumour gets the 5-gray dose, but the surrounding normal tissues, abdomen, spine, or inferior or superior to the targeted isocenter, gets minimal dose. So when he submits his papers and his grants, we can validate his model using the SARP software. Okay, that's the SARP, it's the way to go. It reflects clinical practice. So if you're translating your preclinical observations into a clinical model, which is the aim of a lot of grants, you've already got techniques that validate that approach because we're using image guidance, we're using targeting, we're using fractionated schemes. But if you don't want to use the SARP and you're just doing cell irradiations, or you want to do total body irradiation, you can do that on the Shepherd irradiator, which is a machine down in the basement. It was built before I was, probably. It's not very sophisticated, but it works. It's cesium source, it's held in a lead container as part of the machine. You activate the machine, you push the right buttons, the cesium source comes out and irradiates through a collimator. And you change the size of the lead collimator to change the size of the beam. But you're only getting one beam. And the collimators vary depending on what they're doing. There's a brain collimator, there's a lung collimator, there's a whole field collimator, or there's a cell collimator. And the dosimetry changes depending on what collimator you use. So you have to be cognizant of that as well. But it's less sophisticated because the targeting with a Shepherd reflects you anesthetizing and taping down your animal on the collimator to match the organ that you want to irradiate. So if you're doing lung or brain, you pick the lung or brain slot collimator. It's got a hole in it. You lay your animals over the slot, depending whether you want to irradiate the lung or the brain. You get irradiation. But that's the best you're doing. It's anatomical rather than image guided. It works, it's effective, but it's not very sophisticated. You have to call Bruce Fenton to get trained with this. Once you're trained, you're good. There used to be an eye scanner, but they've changed that to Badger ID now. It's a cesium source. That causes some people to have palpitations. So to use it unescorted, you have to go through a background check. You have to go through a police check, and that can be problematic for some investigators. But it's kind of cheap to use, $41 minimum, $8 an hour. It gives you a fixed dose rate, and at the moment it's about 2 grams a minute. So it works, it's effective, it's not optimal for animal work, but it's perfectly adequate for doing cell work, survival with cells, generating dose response curves for cell studies. If you're grunting through survival with cells, this is probably the way to go. But it does involve that background check for unescorted access. And if you inadvertently enter the room using the incorrect process, security will be on you in a couple of minutes. And when I say a couple of minutes, they get there before I get down from my office. So they're really kind of sharp. You need that security clearance, and there's obviously a dosimetry badge requirement. That is for shepherd, cesium, it works, not sophisticated. Grant people tolerate it, but they like something more sophisticated. So when I said it was built before I wasn't lying too much. The source is in here. Here's the collimator. We put a different collimator on here. We take this plate off, we put a different collimator in there. The source gets drawn through there, it irradiates that way, and then when it's done, it withdraws the source back this way. But you can see it's pneumatically driven. It's not that sophisticated, but it works. And there's a complex way of programming it in time based on a calculation of the cesium decay. And we do the calculation, you just punch in the numbers. That's in an open room, a large room, it irradiates the room. So obviously you're not in the room when you push the buttons. The other approach is to use this, which is inside the vivarium, behind the vivarium wall. So you can use this with animals, put it back in the vivarium in the same room. The cesium is outside the vivarium. Animals that come out of the vivarium, go onto the cesium source or the SARC, have to go into a different barrier room when they go back into the animal house. But this is in it. It's a much larger machine. There's a little drawer here. You get dressed up in a fancy lab coat, you push the right buttons, the drawer opens. You put your mice inside a Perspex Pi device. Pi device sits in this drawer. The drawer gets drawn in. You push the dose you need here, and it irradiates TBI, total body irradiation, for the required dose. And in reality, this is all you can do with this machine, TBI radiation for bone marrow transplants. It's in the vivarium. It's got 2 cesium sources to give a higher dose rate. It's about $100 a run at the moment. There's a subsidy on this. Liz Lemire controls training for this. It's a complex series of procedures you've got to go through. And of course, if you want to use it in isolation, you need that background check as well, because it's an open cesium source. So this works for TBI, and if you're doing bone marrow work in an immune-compromised mouse, this is the thing, because it's in the animal house. You don't have to move your animals around outside the facility. Okay, I think that's all I've got to say, so I'll take questions if anybody's got questions. There we are, we're done. Anybody have any questions?